Awesome. Alrighty, so for this review session, guys, I know it's for a cumulative final. I'm going to spend majority of the time focusing on the new content, on the diabetes content, and then at the end, I will have room for questions for older material. Just realistically, in the 1 hour I have with you guys, it wouldn't be the most realistic to go over like the entire blueprint. So we're going to start with diabetes, and then we'll see what time we have at the end for questions, that type of thing, as far as the final goes. Alrighty, so we're just gonna get right into it, except we're gonna start with this first. This is obviously your final exam. You guys have basically made it through your first semester of nursing school, which is incredible. Now, like, I genuinely mean it when I say that, like, now that you've got it under your belt as far as like how clinicals work and just how much time and effort it takes to be a nursing student, it does get better. And you'll like once you've done these finals, moving forward, you will be able to have something to like reference back to, which helps so much. Like when taking the Patho 2 final, you can remember what the Patho 1 final was like. So that is super helpful. So just push through this last week and then you all get a well-deserved break. As far as study tips go, I try to do these every session. For the final, I mean always, but especially for the final, I cannot stress enough, use the blueprint. Because, okay, so I can't speak on the behalf of your current class or your professors right now, but from what I recall from my patho exam final, it stuck pretty well to the blueprint. Um, so like I said, can't guarantee by no means that there won't be any other questions, but for my experience in Patho 1, it stuck very well to the blueprint. So please use that blueprint for your for your studying, especially if you have like limited time for studying. Since I'm not going over like a comprehensive cumulative review together, those past tutor sessions are all on YouTube, so you can go back and watch those if you find those helpful. Um, with finals, this is my biggest piece of advice, is focus on one thing at a time. It's so hard for me even still today. I was at the library all day and I'm like, peds, public health, psych. Like I'm like thinking about a million different things and I really just need to like sit down and say, okay, for the next 2 hours, I can only think about public health and just start there. I'm going to start unit one, public health, and move on. So really just preventing yourself from jumping around will help your studying be a little bit more effective. Each time you study for something like finals, reviewing what you studied the time before is super helpful. I literally, I think for patho or adult, I would study like 2 units one day. And then the next day, before I could start studying new content, I had to like recite everything I knew from one and two. And then I learned three and four. And then the next day I did one, two, three, and four before I learned unit five, etc. So I was like constantly recalling what I learned. And it's tedious, but it is pretty helpful as far as study tips go. And as always, please prioritize yourself, you guys. Finals are super scary, especially if you're teetering on a letter grade or passing or whatever your situation is. They're stressful. So your health obviously has to come first. Um, if you like your exam obviously matters, but you need to be healthy. Move your body in whatever way that might look like for you. Eat healthy food, get enough sleep, the usual. And also, please reach out for help. At this point in the semester, there's not much we can do as far as grades go, but we are here to still offer support where it's needed for you guys. Alrighty, so to go ahead and get started with patho. As always, if you guys have questions, just interrupt me or put them in the chat and I'll be able to help you out. But we'll get started with the pathology. So first we're looking at the pancreas as an organ. The pancreas has both exocrine and endocrine functions. The exocrine function is that it secretes digestive juices into the duodenum. That's kind of irrelevant for diabetes. It's more relevant for gastrointestinal, which you covered or you will cover in the future. What we're focusing on, though, are those endocrine functions, which is the islet of Langerhans, I think is how you pronounce it, are parts of the pancreas. These work to secrete hormones into the blood, and each one has beta cells and alpha cells separately. The beta cells are what secrete insulin, and alpha cells secrete glucagon. So those beta cells that secrete insulin, insulin is that hormone we talk a lot about that works to lower your blood glucose levels. It does this in a lot of different ways, and I'm sorry, there's a typo in there. I switched to Canva from Google Slides, and Canva doesn't catch typos, so it just, there's some more I would like. But anyways, by promoting glucocellular uptake, preventing glycogen breakdown, and inhibiting gluconeogenesis. So these are all terms you definitely want to be familiar with, but insulin acts to lower your blood sugar in a lot of different ways. Whereas glucagon, that's the one secreted by alpha cells, it increases your blood sugar, causing the glycogenolysis, break and increases amino acid transportation for the production of glucose as well. So again, both glucagon and insulin work in a variety of ways to either increase or decrease your blood sugar there for you. In general, other than insulin and glucagon, there are a lot of different hormones or processes or chemicals that work to also increase or decrease I keep saying blood sugar or blood pressure, your blood sugar simultaneously. So epinephrine is a naturally occurring substance in the body that will increase your blood sugar. So will growth hormone, glucocorticoid hormones, and cortisol. The glucocorticoid hormones and cortisol are important to know that they increase your blood sugar because they directly relate to the fact that steroids, corticosteroids, will increase your blood sugar, which we'll talk a little bit more about later. And then the two main ones that just have a natural effect on lowering blood sugar will be amylin and incretin. And we'll talk a little bit more about amylin because there is a medication that involves amylin to lower blood sugar. Okay. Oh, we're going too fast. Okay. Quick overview for what we're going to be talking about. Diabetes can come in a lot of different forms. There's prediabetes, type 1 and 2, and then we don't really talk much about gestational diabetes. That's diabetes in pregnancy or diabetes associated with other disorders. That's a little bit more in Patho 2. We're really just going to focus on type 1 and type 2 today. In general, the clinical manifestations of diabetes, it's the three Ps. You've got the polyuria, which is the excess urination, polydipsia, that excess hunger and thirst is all in there, and then polyphagia. And then obviously hyperglycemia, that's glycosuria is sugar in the urine, which also there's hyperglycemia and hypoglycemia that would come with diabetes as well. Alrighty, so for type 1 diabetes, this is the absolute deficiency of insulin that can be caused by a lot of different things, but it's most commonly caused by kind of a combination of autoimmune processes, genetics, and/or environmental influences. Type 1 diabetes is not the result of a poor diet or lifestyle. One of my best friends, he gave me permission to talk about him a little bit. He's a type 1 diabetic. And he says he can't stress enough how many people, when they find out he's diabetic, say things like, but you're skinny, but you work out, but you eat good, like you don't look like you have diabetes. So type 1 diabetes really isn't, the stereotypical assumption that's made when you hear that someone has diabetes. They can be young, old, fit, unfit, however it might appear, but it is not the result of a poor diet or lifestyle choices. The clinical manifestations that differentiate type 1 diabetes from type 2 diabetes would be it comes on suddenly. It often appears in childhood. My friend, for example, was diagnosed at age 7. It often, when it starts with that sudden onset, it's often more severe as well. So it's fast and it's pretty severe. And it does come with that polyuria, polydipsia, and polyphagia that we talked about. It can also be accompanied by a sudden weight loss, fatigue, and frequent infections because people with diabetes are immunocompromised. And with type 1 diabetes, there is a risk for acidosis or diabetic ketoacidosis that we'll talk here a little bit more in a minute. And I did just find some quick YouTube videos. We're not going to watch them together, but for your studying, these just explain type 1 diabetes a little bit more in depth, or if you're a visual learner, that might be able to help you study as well. So then in opposition to type 1, type 2 diabetes is the relative deficiency of insulin that could be caused by obesity, lifestyle genetics, and also metabolic syndrome. With type 2 diabetes, there can be like kind of a combination of factors that cause it. You can have impaired insulin secretion, so the pancreas, those beta cells themselves actually aren't secreting insulin in the demand that the body needs. But you can also have insulin resistance, where the cells actually just are not willing to accept insulin and its effect, which then affects that decreased glucose uptake as well. So it does have that different pathophysiology in comparison to type 1 that we talked about. Um, to differentiate it a little bit from type 1 diabetes, it does have a slower onset. This can kind of develop over months to years of, obesity, poor lifestyle habits, just a continued pattern that can cause type 2 diabetes. And because of that, the symptoms are typically less severe in the beginning. So if you're not going in for regular, appointments with your primary physician, et cetera, you might not know you have diabetes for a while. It is easier to control than type 1 diabetes because in almost all cases, you still have some level of insulin. So it's treated by medication easier. And with this one, there's an increased risk for HHS, which is another acute complication that we'll talk about in a moment. For the labs for this exam, I definitely would be familiar with labs for diabetes and how those look and what they mean. There's that fasting plasma glucose. So patients need to fast for 8 hours prior to that test. Your random glucose, that's just non-fasting. You can collect it whenever. Oral glucose tolerance, capillary blood glucose, that's the finger prick that hopefully we've all done by now in clinical, or I think you do it in skills. And then there's the hemoglobin A1C, HbA1c. This is important to know. This monitors your blood sugar fluctuation over the past 120 days. So it's actually a pretty cool test. But that one's not going to really tell you much about your current blood sugar, your current state. That one is overlooking the past, essentially, 4 months of your blood sugar fluctuation and general control. So the higher the percentage is with that one, the worse your blood sugar control is. And then serum ketone level, that should be negative. And we'll talk about that more. But in healthy people, that should always be negative. So the normal versus pre-diabetic versus diabetic, I would definitely be familiar with those ranges. There's a decent chance you'll be given the range and we'll have to kind of work with what state that lands you in. Urinalysis, this is the testing of the urine for different values or the presence of bacteria, those types of things. It's used for UTIs. They test specifically for urine ketones. These should be negative. In healthy situations, serum and urine ketones will be negative. They can become positive in type 1 diabetes, and they also can indicate that diabetic ketoacidosis that we talked about, or will talk about, I should say. Urine protein also should be negative, but small protein, that microalbumin, can come back positive in diabetics. And urine glucose also should be negative, but will often be positive in diabetes, and that's an effect of hyperglycemia. Alrighty, here's the first practice question for you guys. Which of the following findings is considered to be abnormal? Awesome. Yeah, you guys are all correct. That one is going to be A. The other three all technically fall within the normal ranges for the different values. Which of the following statements regarding the pancreas is false? Awesome. Yes, you guys are all correct. That one is D. In diabetes, the pancreas cannot produce insulin from the beta cells. Glucagon comes from alpha cells. Which lab test measures the fluctuation of blood glucose levels over the past 120 days? Awesome. Yes, you guys are all correct again. That one is that hemoglobin A1C, option B. I'll give you guys a second for this one. The question is, a 7-year-old male patient is diagnosed with type 1 diabetes. The mother expresses concerns for what she could have done differently to prevent this. Which of the following is the most appropriate response by the nurse? Awesome. Yeah, you guys are all correct. So this one is A. B is type 2 diabetes. It's not an appropriate response for type 1 diabetes. Um, you see, as a nurse, you are supposed to provide education and answer those questions by family members. So you wouldn't want to just defer all questions to the provider because chances are the provider is not going to be around to just pop in and answer some questions. And D just isn't a therapeutic response as far as nursing goes. You can be honest and say, like, I'm not sure, let me check on that for you. But a simple I don't know doesn't typically suffice. So yes, that one was A. Which of the following will decrease blood glucose levels? Awesome. Yeah, you guys are killing it. All correct. That one is C. A, B, and D all work to increase blood glucose levels naturally. Alrighty, so that brings us into the chronic complications of diabetes. And I'm sure you guys have heard about diabetes in adult and patho and skills. It never goes away. It never goes away. In peds, you talk about pediatric diabetes, you talk about it in adult too. You talk about it in maternal infant nursing with gestational diabetes. It never goes away. So being familiar with these complications is just helpful as you move through nursing school. Both type 1 and type 2 diabetes can cause a plethora of complications, unfortunately. And in general, the more poorly managed the diabetes is, the higher risk for these complications later in life. So as far as macrovascular effects go, there's an increased risk for a lot of different life-threatening, life-altering conditions. There's coronary artery disease, myocardial infarctions, which are those heart attacks, hypertension, vein distension, vein disorders, and stroke there. Microvascular, specifically, you're looking at the eyes and the kidneys. It can cause diabetic retinopathy or changes in the eye and can ultimately cause blindness. And nephropathy are those kidney changes, just derived from that word nephropathology, pretty much. And then also recurrent infections. You are often immunocompromised when you're diabetic. Um, there's also an increased risk for peripheral neuropathy. So that is going to be the neuropathy of your extremities. Typically, patients will report burning, tingling, and numbness in their extremities and decreased sensation. So this actually is what puts them at a risk for a lot of different, like if someone with diabetes loses their limb, it's often because they got an injury, something happened, and they couldn't feel it, and it became infected, gangrene, however it progressed. A lot can happen when they can't actually feel parts of their body. And then autonomic neuropathy is another type of neuropathy that can occur that can impact your autonomic nervous system. So everything your body does without you actively thinking about it, which is like, your heart rate, your breathing, all those types of things, your digestion, that's all part of the autonomic nervous system. Like I was saying with like losing limbs and stuff, there is an increased risk, especially for ulcers of the feet, because of that decreased sensation. Like I said, you get a sore on your heel, you never really look at it, you don't feel anything, and before you know it, your foot is necrotic and it's infected, and you end up with your foot amputated. I think the most amputations I've seen, like I've seen a few that like have lost toes because of their diabetes, but I've worked with quadruple amputees who had type 2 diabetes and lost all four of their limbs. So it is a pretty serious complication that you might even see just on like med surg rotations as well. That first serious acute complication is diabetic ketoacidosis, which is shorthanded to DKA. This complication occurs in type 1 diabetics, and it's characterized by severe hyperglycemia with a blood sugar over 250, severe insulin deficiency, and basically what happens is the fat is used for energy, which leads to excess acid in the blood, creating that acidotic state. And diabetic ketoacidosis is a life-threatening emergency. This requires often hospitalization, even in the ICU, to correct. And if not treated, it would be fatal. The clinical manifestations are fruity breath that results from the excessive hyperglycemia, those positive urine ketones that we talked about, Kussmaul respirations, those are those rapid, deep and labored breathing. That's your body trying to compensate for that acidic state. in your body. Hyperglycemia, all the same symptoms that polyuria, polydipsia. You can also have nausea and vomiting. Your body might also enter somewhat of a state of shock, which can cause hypotension and tachycardia together, dehydration, and then you can also be super drowsy, which can progress into a coma. There are such things as diabetic comas that can result from things like that. Alrighty. Treatment. At the beginning, you're going to give regular insulin through IV push. We'll talk more about insulins later, but that is the only one that can be given IV. And then it's followed by low doses of continuous insulin. You also would do normal saline at first as far as IV fluids go, but as the blood sugar drops between about 250 to 300 milligrams per deciliter, you would switch to 5% dextrose in 0.45% saline. And as always with anything with diabetes, you want frequent blood sugar checks. I would recommend knowing the treatment regimen for DKA for the exam. And again, I found a YouTube video that breaks it down for you a little bit. If you want, again, if you're more of a visual learner and would understand the process of DKA better that way. Fun fact, the vascular changes in the eyes is from diabetes being uncontrolled through. Yeah, see, I didn't know that. That's cool. I mean, like those affects everything you do, like with diabetes management. Like every time my friend is low, I'm like, do something about it. Or when he's high for hours on end, I'm like, do something about it. Like I don't like when you're living outside of this range because I mean, 5 years down the line, there could be an impact from anything being uncontrolled. So thank you. That's cool. The other acute complication that we need to know is HHS, hyperosmolar hyperglycemic state. This is the acute complication that we talk about for type 2 diabetes. And this one, it's characterized by a blood glucose of over 600 milligrams per deciliter, which is very, very high. Um, the highest I've seen in practice was like 500, but I've had patients come in and they're at like 300 or 400 and they're like, this is nothing. Like I've been at 1,000 before. And I'm like, that's like not a flex. But HHS is characterized by over 600. This one has a slower onset in comparison to DKA, and it's most often caused by an underlying infection. The main clinical manifestation of HHS is severe dehydration, which can be, there are so many symptoms of dehydration, but think thirst, dry mouth, weakness, dry mucous membranes, that decreased skin turgor from health assessment, those types of things. And then the dehydration can cause hypotension and tachycardia, which then can lead into hypovolemic shock. And this one can also cause that drowsiness, those neurological issues, which can progress to that diabetic coma that we talked about. Just like DKA, HHS is a life-threatening emergency, requires hospitalization, again, often in the ICU, um, and hospitalization afterwards to get that blood sugar back leveled out. The main difference in treatment between the two of them is that in HHS, you push more fluids because it is characterized by such dehydration. You're giving larger amounts of IV fluids, but the pattern for IV treatment is similar in the sense that you do regular insulin, and then once the blood sugar is about 300 milligrams, you can switch to dextrose and IV fluid, that 5% and 0.45% normal saline. And again, those frequent blood sugar checks. Hypoglycemia, this can occur in both types of diabetes. This is just low blood sugar. For the purpose of this class, it's blood sugar under 70. Like all lab values, you'll see kind of varying ranges, but under 70 is for patho. Hypoglycemia will have a rapid onset and progression as well. Clinical manifestations, you can have headache. There's kind of a lot that come with it. Agitation, irritation, hunger, anxiety, tachycardia, palpitations. I almost think of it as like if you stand up too quick and you're dizzy and or like you're clammy and you just don't feel good, or even like having the stomach flu, that overall body feeling you get, not a fun feeling at all. That cool, clammy, sweaty skin, being pale, altered behavior. You can also have confusion and loss of consciousness. Really funny. my friend with diabetes, if he's low, if he's hypoglycemic, he genuinely will forget my name. He doesn't like he'll look at you and he knows that like you know each other and that if we're hanging out, we must be cool, but he won't remember who I am, how he knows me. And he doesn't tell you either. He just has a look in his eye, and I'm like, "What's my name?" And he genuinely forgets until he's back in a normal blood sugar range, and he kind of just is able to remember everything again. So hypoglycemia can kind of present in some funky ways, but those primary ones definitely of like the agitation, weakness, that cool, clammy, sweaty skin, those are definitely important to remember. Um, if your patient who's hypoglycemic is able to swallow, as in they're conscious and communicating, you're going to want to give some form of oral glucose, about 15 grams of an oral carbohydrate. Examples would be orange or apple juice, a teaspoon of sugar, or a glucose gel. My friend does glucose tablets, so they come in like a bottle, and he just eats a few glucose tablets, and those will raise his blood sugar. Um, Once they do that, you're going to want to recheck the blood sugar and, kind of determine then if we're heading in the right direction, if we're still too low, and you can repeat that oral glucose administration every 15 to 20 minutes, up to 3 times, as you continuously check the blood sugar to make sure it's going back into a normal range. Sometimes, though, your patient with hypoglycemia will not be responsive or they'll be unable to swallow. That's often more in like severe cases of hypoglycemia. In those cases, you would either administer IV dextrose over 1 to 3 minutes or subcutaneous or intramuscular glucagon with a 10-minute onset. So those orders might vary in the chart, but those are two options for hypoglycemia when your patient is not able to eat anything essentially. The dawn phenomenon. This is a phenomenon in type 2 diabetes where the blood sugar is just naturally higher in the morning between 5 and 9 a.m. This is just important to know as nurses because in the morning, especially if you're coming in at 6 or 7 for your shift, um, you might need to increase insulin based on like a sliding scale order or something to accommodate for that higher level during that time. It's kind of like it's a phenomenon, so it's kind of mysterious in that sense, but it could be caused by changes in the circadian rhythm or hormones that are released when you're asleep. So, alrighty, which of the following are clinical manifestations of DKA? Select all that apply. Okay, awesome. I'm seeing some come in. You guys are correct. This one is A, B, and C. The three of those are symptoms or signs of DKA. D is just the opposite. That's that low blood sugar. And with DKA, you would expect positive urine ketones. The nurse has a patient who has a blood glucose of 30 milligrams per deciliter and is unconscious. What would you expect the nurse's next action to be? Select all that apply. Okay, yes, that one is B and D. A and C, if they were conscious, that would be acceptable. E, that would lower blood sugar even more, so we would avoid that. So B and D are correct for this one. Which of the following is not characteristic of hyperosmolar hyperglycemic state or HHS? Awesome. Yeah, you guys are correct again. That one is C. A, B, and D are all characteristic of the HHS. Again, C would be characteristic of DKA. If you take anything away from this, I guess you're taking away that DKA has positive urine ketones because I think I've said that like 30 times at this point. But it must be important. So, alrighty. So that was everything for the pathology of diabetes. We'll go ahead and move into the pharmacology. So this will have an emphasis on insulins and those oral medications specifically for type 2 diabetes. Insulins. Um, I would assume most, if not all of you, have given insulin or watched insulin administration in clinical at this point. Super, super common, especially on that med surge, in the long-term care facilities. A lot of people are on insulin. So insulin, again, this is what will lower blood sugar naturally. It is a high alert medication, so think of everything that comes with high alert medications. There's that oftentimes the dual nurse confirmation, specialized disposal. It might be behind lock and key, like those types of things. Insulin will always come in an orange tip syringe because it has specific unit measurements. That is super, super important. There have been cases, and there's even a documentary, I think, where people use milliliter syringes and it's a lethal dose of insulin. So you need those orange tip syringes that are unit measurements since insulin is delivered in units. Um, Adverse effects, the main one that you'll have to know is hypoglycemia. If you give too much or you give it and it's not compensated by carb intake, chances are their blood sugar will drop into a hypoglycemic state. So again, knowing those symptoms, being sweaty, pale, clammy, lethargic, tachycardic, etc. And with that, you can reverse it. So if you just gave the patient insulin with their meal and then they decided not to eat any of their food and they become hypoglycemic, you would encourage glucose intake to get that back up into a normal range. There can also be injection site reactions because we're about to talk about it more, but insulin's always given subcutaneously in like the abdomen, etc. So you can have injection site reactions and pain as well. So again, the sites for subcutaneous insulin, the abdomen is preferred, and like you would switch sides and stuff in the hospital. Upper arms, thighs, and the glutes are also all acceptable regions to do it. For the insulin sites, you want to avoid heat, massage, excessive exercising of like the specific site and areas that have skin problems. Just be tips for that. As far as insulin regimen goes, the most common is a mixture of regular insulin and NPH administered before morning and evening meals. And there are also just pre-mixed combinations that people take. Um, the main thing I see, at least during clinical practice, is sliding scale insulin coverage. This is a rapid acting insulin given based on the result of the glucometer or that like finger prick test. So an example would be like if that blood sugar is 151 to 200, administer 2 units. Um, I had a nursing internship in Chicago this past summer, and I genuinely think like 75% of my patients were diabetic. And every single one had sliding scale insulin protocol. And I would check their blood sugar, and then the nurse would instantly use that sliding scale to determine how much insulin to give. And that was, I mean, a lot of patients were 4 times a day that we were doing that. So that's pretty common. So I'd be familiar with that. And then always, always, always check for other drugs that can impact blood glucose, like steroids. Steroids will naturally increase your blood glucose level. So that's something you have to take into accommodation when you're preparing anything that can lower or increase blood sugar. Alrighty, you guys are gonna hate me. I do recommend knowing all of this, and I know that that is not ideal. I remember I had like a crash out, and I'm just being fully honest at the library because I could not for the life of me remember the onset, peak, and duration of all the different types of insulin. But I would recommend knowing it. Um, we'll go through it here in a minute, but flashcards help. I had a friend studying with me, and we did insane active recall, like you're not allowed to move on until you can tell me all of this. Keep going type of thing. But yes, I would know everything on this chart. The nice thing is a lot of it's the same. If you look at contraindications and route, largely the same. But knowing those differences will help you in practice and on the exam as well. So there's your rapid acting insulins. First, you have glucine This one is given 15 minutes before meals or within 20 minutes of starting a meal. The contraindication is always hypoglycemia for all of them. Route subcutaneous, that onset is the fastest onset, fastest peak, and near shortest duration. Um, so however you can best learn those ranges, again, flashcards helps a lot of people with those. Or you can come up with like acronyms with the first letter of the numbers, whatever works best for you. More rapid acting insulins, you have Lispro and Aspart that's given 15 minutes before meals. Also, sub-Q, that one has an onset of 15 minutes. 1 to 3 hours is the peak. 3 to 8 hours is the duration. Short acting, this is the prototype is just regular insulin, and it can come as Humulin or Novolin. But I just know short acting, this is regular insulin. This one's typically given 30 to 45 minutes before meals, and it can be used in an emergency. This is the type of insulin we talked about with DKA and HHS. Um, Again, contraindication, hypoglycemia. It's given sub-Q. This is the only one that's given IV. So regular insulin can be given IV, again, which is why we use it for like DKA and HHS. Intermediate acting, it's those NPH. Those are those cloudy ones. You talk about that a lot in skills. Humulin N and Novolin N. Hypoglycemia is more likely in mid to late afternoon. Subcutaneous administration, the duration can be all the way up to 24 hours on this one, which is, I mean, that's just the longest. It's a long time. And the onset is 1 to 1.5 hours. And then lastly, there's long acting. This is the Detamir and Glargine insulins. With the long actings, they have an important note that you cannot dilute or mix them. That kind of makes them unique from some of the other ones. It's still given sub-Q. Contraindication is still hypoglycemia. This one, the onset is 1 hour, and they have different durations. Neither of them have like a peak just because they last for so long, but they do have slightly different durations there. So again, just know the general. The most important thing too is if the question is phrased in a way of like, your patient's going to eat in 30 minutes and they need some form of insulin, what would you expect to give? You need to know which one then would have an onset of about 30 minutes. That would be more the way that the exam is going to test you on that kind of stuff.
I have a question.
Yeah.
When, for example, she asked a question, they say your patient wanna get, for example, the breakfast at 7, for example, at 7, but we're gonna give her a rapid active, like a glycine.
Okay.
What time? Because the breakfast start at 7, and then we're gonna give her a glycine. I have to give in the meals like in 6, 10 minutes or 5 minutes before.
Yes, that's exactly how they would ask them and that would be correct. Yeah.
Okay.
Yeah. That
And
would
then
be
the peak, that mean I have to check after 1 hour. Is that what the peak?
Yeah, the peak is when like the effect of the insulin would be at its highest. So it's
Mm,
lowering the blood sugar the most. So it would
mm,
be, I mean, good practice to check the blood sugar then to make sure that it didn't go too low. Because if it was gonna go low, it would most
mm.
likely occur during that peak time. So yeah, you'd be
Oh,
correct.
for example, if the peak after 1 hour you think it was too low, that one you have to give maybe some snack, right?
Yes, yep.
Okay.
Yeah. A lot of the times patients on insulin, you're
Mm,
checking their insulin or sorry, their blood sugar, like I said, with every meal or four
mm,
times a day or sometimes more. Um,
okay.
so yeah, you'd be checking it a lot and then you can adjust with snacks or more insulin or however what they need.
Okay. Okay.
Awesome. Alrighty, thank you for asking that. So those are all the insulins. We're going to move on to the oral medications. There are, I think, 4 or 5 that we're going to go ahead and talk about. The first one is the sulfonylureas. I hear commercials for these all the time, like literally all the time. I feel like they're always on my TV. The prototype for this is glyburide. And there are second generation medications, glipizide and glimepiride. Guys, they all start with G's. Like, if your brain is on overload and you can't, for the life of you, remember any more medications, these all start with G's. And they look pretty similar too. This is used in type 2 diabetes because its action requires functioning beta cells. So those beta cells might not be working to the best that they possibly could be in type 2 diabetes, but they work. And that's required in this medication. So medications like this would be absolutely ineffective in a patient with type 1 diabetes. Um, it's not on here, but like a good practice question would be, your patient with type 1 diabetes comes in and they're really, really sick of all this insulin. They ask why they can't take a medication like this. Your response as a nurse would be, unfortunately, medications like this require beta cells, those cells that make insulin, to be functionable in order to take this medication. And then your patient will go, oh, okay, like that makes more sense. Thanks for explaining it. That would be like the framework for questions like that. Adverse effect, hypoglycemia, again, because it'll work to lower blood sugar, and weight gain as well. For the sulfonylureas, the main contraindication is an allergy to sulfa-based medications. And again, this is in the name, sulfonylureas, sulfa allergy. I would know that. And for this one, it's typically given about 30 minutes before breakfast. And it does have a lot of drug and herbal interactions. So as always, you're going to want to check their med list, ask if they're taking any supplements or herbal products not listed. And then also always check that allergy list and confirm with the patient that there are no allergies to sulfa-based medication. Then we have alpha glucosidase inhibitors. The prototype here is acarbose, alpha, acarbose, AA. I like to think of any way possible to help people remember these. This is also given in type 2 diabetes, and it is given in combination with insulin or other oral meds like sulfonylureas. You'll see there are a lot of instances where multiple of these oral meds can be given together to have like the most effect for the patient. Adverse effects for this one, it can cause GI issues, just general distress, that nausea, vomiting, diarrhea, and pancytopenia, which you'll learn a lot more about, but that would be like low counts of pretty much all your blood cells, like red blood cells, white blood cells, neutrophils, etc., which puts you at a risk for like anemia and bleeding, those types of things, infection as well. Implications, this would be taken with the first bite of each meal, and you would assess for GI effects primarily. The biguanide, this is another medication. Its prototype is metformin. This is a first-line medication used for type 2 diabetes. It is given alone or in combination with other meds. The main adverse effect to know is that there's a black box warning for lactic acidosis in older adults. This medication actually does not put you at a risk for hypoglycemia or weight gain, which is part of why it's a first-line medication, just lower risk of those adverse effects. Contraindications would be infection and trauma, and this one is also taken with the meal, and it differentiates it from some of the other ones. You would need to hold the med prior to any diagnostic tests using iodine contrast media. And forgive me, I did not look into why that is, but it likely would cause a reaction with the iodine contrast. But just know that you would hold metformin prior to contrast containing iodine, which they use a lot in CTs, like CT with contrast would have that contrast media. Then there's the DPP-4 inhibitor, or sitagliptin. This is a medication also used in type 2 diabetes, and it can be given alone or with metformin for that increased effect. Um, it can have adverse effects like rash, angioedema, upper respiratory infections, so more like hypersensitivity like adverse effects. There is a black box warning for severe joint pain. What makes this one unique is a patient can continue the med even if they are having that severe joint pain, but they would need to tell their provider right away. Sitagliptin can be taken with or without food, And as always, you're going to assess for those adverse effects and educate them on that joint pain and what they should do if that were to occur. Amylin analogs, we mentioned this way back at the beginning. Amylin is something that your body has that naturally will help lower blood sugar. The prototype here is pramlintide. This medication overall is pretty new. I think your PowerPoints for class talks about like pens that it comes in. This is, like I said, a newer development. It can actually be used in type 1 and type 2 diabetes in combination with their insulin. There is a black box warning for hypoglycemia, so big, big risk for a pretty excess drop in blood sugar. And this is administered subcutaneously. It would be taken immediately before meals. Um, it's not mixed with insulin, so they would have to be two separate injections if you're doing like your insulin subcutaneously as well. It has a rapid onset, which is why you would take it with meals or immediately before. And part of what it does is it slows your gastric emptying, which kind of gives your body more time to work with the carbohydrates that are being digested. I pulled this from your PowerPoint from class. I thought it did a good job at just summarizing key points in treating type 1 diabetes and type 2 diabetes. It just compares that initial treatment for both and what's most commonly prescribed. So I would recommend looking at that if you have time.
Excuse
And
me, I have a question.
yeah,
Are you gonna send us this PowerPoint?
yes,
Okay.
after at the end, I'll collect everyone's emails. I'll send out the PowerPoint and then it's also posted on YouTube for afterwards.
Okay, thank you.
Yeah, of course. Alrighty, here's the first practice question. Which of the following can be given intravenously? There's a question. Would you have to choose between regular insulin or amylin on a patient, or could you give them both? You can give them both. It can be administered alongside insulin. It would just be pretty crucial that you do those blood sugar checks because there is that pretty immediate risk for hypoglycemia. Um, it also would want to be with mealtime so that the patient eats carbs while also the effects of those kick in. But you wouldn't have to like choose one or the other. And yes, you guys are all correct. That one is D. That's that Humulin R. The other three are all subcutaneous. Which of the following syringes is used for insulin? Awesome. Yeah, you guys got that fast. That one is a definitely never mess that up. That's partially why it's a high alert medication, because you do need a second nurse to verify that. Which medication is contraindicated by an allergy to sulfa-based medications? Awesome. Yep, you guys are all correct. That is C. That's that sulfonylureas that you would have to check for that allergy to sulfa medications for. When would you administer Aspart or Lispro insulin? So you guys are all correct. That one is D. That's one of those rapid acting insulins. Good job. What is the black box warning for metformin? Awesome. Yep, that is lactic acidosis in older adults. It's listed as an adverse effect for anybody, but it becomes a lot more serious of a risk and that black box warning when it is in older adults. Alrighty, that is everything I had on diabetes, pathology, and pharmacology. I'm going to tab through these pretty quickly, and then if people want to go over anything in specific, I can do my best to help you there. I just kind of pulled the blueprint information so that if you guys are using my PowerPoint to study, you can refer to this instead of having like a million different documents. Everything unit 1 and 2 that you should focus on, 3 and 4, and then 5 and 6. Again, the blueprint, in my experience, has been pretty concise. So again, if you have to focus on anything to study, use the blueprint. They made it, like they did for a reason. No one's trying to make your life harder than it needs to be. And per usual, that is all I have for you guys. Feel free to stay, ask questions about anything from the course, about preparing for your final, or go. And if you missed either QR code, here is everything for you. Um, if you would like everything emailed to you tonight,